The following video demonstrates the removal of Cyclops-like lesion after ACL reconstruction with a quadriceps autograft. These are our disclosures. Arthrofibrosis is a debilitating complication after ACL reconstruction with a reported incidence of 2 to 35%. It is characterized by loss of range of motion, particularly with terminal extension, although it can affect both flexion and extension. A subset of patients may even develop a Cyclops lesion, which frequently requires subsequent surgical procedures to address the issue. Most of the current literature have reported on patella tendon and hamstring autografts. As quadriceps autograft has slowly gained popularity, there have been reports of arthrofibrosis and the development of Cyclops-like lesion in this cohort. We present a patient that developed this lesion after ACL reconstruction with a quadriceps autograft in our surgical technique to remove this. The patient is a 16-year-old male high school athlete. He previously had a left ACL reconstruction with quadriceps autograft performed by the senior author 8 months ago. He presents in clinic with persistent pain and terminal extension and has an extension lag of 10 degrees. The image on the right demonstrates significant quadriceps atrophy in the left knee 2 weeks prior to the surgical procedure. An MRI revealed dense fibrotic tissue formed anterior to the ACL graft, which are shown in the images pointed by the white arrows. After thorough discussion, the patient elected to undergo surgery. The surgical procedure was performed with the patient in a supine position on a flat table. An EUA was performed, which confirmed an extension lag of 10 degrees. Standard anterolateral and anteromedial portals were established, and a full diagnostic arthroscopy was performed. This revealed an intact ACL graft with extensive fibrosis just anterior to the graft. A motorized shaver was then introduced to begin the debridement process, and with careful attention not to disrupt the ACL graft, as this fibrotic tissue can be closely adhered to the graft. A probe can sometimes be used to develop the plane in between them. In addition, part of the fibrosis can extend into the intercondylar notch as well as the native PCL as demonstrated here. Careful debridement should also be completed in this position as well. An arthroscopic grasper was then introduced to retrieve the Cyclops-like lesion. Alternatively, one can use an arthroscopic biter to complete this process. The excised tissue was sent for pathology review, which revealed benign fibrosis and degenerative necrosis of synovium. The motorized shaver was then introduced once again to complete the final debridement process. This involves debriding the suprapatellar pouch, medial and lateral gutters, and retropatellar space to complete the lysis of adhesions. The ACL graft can be visualized here, showing signs of appropriate healing and ligamentization. The Cyclops lesion has been completely removed. The knee is then ranged through range of motion in deep flexion and full extension to assure full range of motion can be achieved without any signs of soft tissue or graft impingement. Post-operatively, the patient can weight bear as tolerated without any restrictions on range of motion. We advise the patient to undergo aggressive physical therapy with emphasis on terminal extension training and quadriceps strengthening as well as swelling control. We also follow up these patients more frequently with an interval of 2 weeks for the first 2 months to assure appropriate progress was being made. Recent studies have suggested that a quadriceps autograft may have higher incidence of extension deficits compared with other graft choices. One study even showed a relative risk of 2.68 compared to hamstring autografts. Another study showed approximately 7% of the patients that undergo an ACL reconstruction with a quad autograft may need a subsequent lysis of adhesions. The same authors further identified risk factors, including female gender, femoral tunnel size greater than 9.25 mm in male patients, as well as a concomitant meniscal repair at the time of surgery, to be significant risk factors for this to develop. This should be kept in mind by the operating orthopedic surgeon. And that concludes our presentation. Thank you for your attention.